Welcome to the conference session titled Transplant and Bone Marrow Failure. Thank you for joining us. My name is Nyari Sireu, Patient and Professional Program Coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, that you submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Krishna Gundabolu. Dr. Gundabolu is an associate professor in the Division of Hematology Oncology, Department of Internal Medicine at the University of Nebraska Medical Center. He's a member of the Myeloid Neoplasms and Acute Leukemia Group at UNMC and is the Associate Director of the Blood and Marrow Stem Cell Transplantation BMT program. Dr. Gundabolu's main clinical research interests are in myeloid neoplasms, thrombosis, bone marrow transplantation, and cellular therapies. He's a member of the NCCN Myeloproliferative Neoplasms Committee. With that said, welcome, Dr. Gundabolu.
Thank you very much, and I'm very excited to be here. I know we have a lot of virtual audience. Hopefully, you all will enjoy the talk, and thank you for the foundation for giving me this opportunity. And it's great talking to all of you today. So for the next 40 minutes or so, we'll talk about the landscape of myelodysplastic syndromes and aplastic anemia and associated bone marrow failure syndromes, and what is the role of transplant, and when it is considered, and what are the pros and cons of it. And mostly it's a bird's eye view what I'm going to give you all, and I look forward to the discussion. And these are my disclosures, nothing very specific to this talk. So these are the objectives of our talk, which I just talked about. So I'll start with a case. It's a 62-year-old man with no significant past medical history, was referred to us because he was progressively getting more weak, and the primary care doctor did a blood count, and it revealed some cytopenias with low white blood cell count, as displayed there, with a neutrophil count, which is a type of white blood cell count which is important in fighting infections, and the platelet count, which is a cell which is important in bleeding and clotting. When they are low, people tend to bleed. And the hemoglobin, which is a surrogate marker of how many red blood cells we have in the blood. So when the number of red blood cells are low in circulation, the hemoglobin goes down. It's a surrogate of how many red cells we have in circulation. So they did a bone marrow biopsy because the blood counts were low. They were about 2% blast. The chromosome analysis, which is an important aspect I'm going to talk about, showed normal genetics. For a male, it is there is this Y chromosome, and if there are any changes in the genetic material, you tend to see this in this particular test called as karyotype or cytogenetics. So they also do what is called as a fluorescent in situ hybridization, the so-called FISH panel, which is also a type of genetic test you do in addition to the karyotype. So often I describe karyotype as a family picture. You line up all the chromosomes in the cell, all 23 pairs of them, and take a group picture. Okay, and then the fish study is mostly like, you ask for a very specific set of person or people, and you take a specific picture, meaning if there is something very uniquely different in particular aspect of the chromosome, you specifically ask for it. So it's almost like taking a solo picture, if you will. That's the fish. So these tests are part of the initial testing process. So we'll go into that in little more detail in the coming slides. And they also did a mutation profile, which is one of the newer things which is different, and I'm going to show you in the subsequent slides. And that showed all these mutations which are listed there. So what should you do for this patient? Should you start them on a drug like erythropoietin, or should you just ask the patient to go home, have a good time, and come back in 6 months? Or should you start the patient on a drug like lenalidomide, or should you refer this patient for consideration for a bone marrow transplant or a discussion about bone marrow transplant? So this is a case we will build upon for the MDS discussion. At the end, we'll come back to this slide, and we'll probably go over why we do what we do. With that being said, myelodysplastic syndrome is pathologists are very particular about how it is described. So this is important. So a bunch of pathologists and hematologists sit down in a room, and they make up these guidelines and update them as the evidence comes up. So they publish a huge complicated manual or a textbook every now and then, and nobody can remember every bit of details. So we often refer to them, and try to comply by them, because they put a lot of thought and a lot of evidence into whatever they do. So with that being said, myelodysplastic syndromes are often defined as a group of hematopoietic stem cell disorders where there are cytopenias, meaning low blood counts, dysplasia, meaning the blood cells are looking abnormal under the microscope. That is called as dysplasia or dyspoiesis. Anytime you read those words, that's what it means. So they're looking goofy under the microscope. One or more major myeloid cell lines are affected, and there is ineffective hematopoiesis, meaning myeloid cell lineage affects these three blood groups, blood cells, as we discussed: the platelets, the white blood cells, particularly the granulocytes, and the red blood cells, which is equal to anemia. So having low blood counts is a common theme in myelodysplastic syndromes, and having some form of abnormal looking cells under the microscope is the second common prerequisite for defining somebody having myelodysplastic syndromes. And also they are clonal hematopoiesis. Mind you, that's an important word. So clonal meaning, these are bunch of cells which share similar abnormalities, if you will. Sometimes these clones can be one clone, they could be multiple clones, if you will, but it's a clonal process, so which can be distinguished based on various assays like flow cytometry or cytogenetic studies, as we just talked about and we're going to talk about. In 2016, they kind of updated this, but precisely, it talks about the same ineffective blood production or hematopoiesis. What it means is, the bone marrow is packed with a lot of cells, but unfortunately, these are very poor quality cells. So I often describe it to patients as, you have a gigantic car factory where you're like constantly producing cars or whatever parts you're producing, and the assembly line is really busy producing them, but the parts of the car are so poor, the minute they leave the manufacturing plant, they break apart, or even they break apart while they assemble it. So that's called as ineffective hematopoiesis, meaning the cell quality is so poor that they die at source. So it's not one of the most common cancers, So the incidence is around 4 to 5 people per 100,000 per year, and it's more common in older population. After 70 years and 80 years, it becomes even more common compared to younger population. So, so men are involved. Men have a little higher incidence, but nevertheless, it's not a huge difference. So, what are the risk factors? DNA damaging agents, environmental risk factors, sometimes having hereditary causes. All these could be considered as some of the identifiable risk factors, but in reality, a lot of times we cannot find a particular risk factor. So this is a nice slide where you can see the amount of progress which was made, over the period of time. The first French-American British classification came out. Mostly it's based on how the pathologists see cells under the microscope. Subsequently, the chromosome analysis, you remember we talked about the karyotype. So that was taken into the equation, and they came up with this International Prognostic Scoring System, IPSS, what it is referred to, and they divided it into 4 subcategories I'm going to show you. And subsequently, they added this new category called as deletion 5q. It's a unique subtype of myelodysplastic syndrome, and it has prognostic relevance. And these drugs, azacitidine and decitabine, where they were introduced somewhere around 05, lenalidomide particularly for the deletion 5q syndrome. So somewhere around 2005, 2006, these drugs came into clinical practice. And believe it or not, even to date, we don't have a whole lot of drugs into the market. So I'm not going to go into the non-transplant options today, but the next major development in MDS came in 2012 when they revised this IPSS as they fine-tuned the degree of low blood counts and the number of blast cells in the bone marrow and so forth. So they kind of were able to split it even more into 5 subcategories, if you will. And there is oral decitabine which came up in 2020. There's a drug called as luspatercept. I think I'm not going to go into them, but it's revised in 2022 with the advent of what is called as molecular IPSS now. So this is probably one of the most important advances in the MDS field, particularly in the decision process of transplant. This has really changed the way we look at the MDS. So I'll walk you through this slide. Each time I see anybody with myelodysplastic syndrome in my clinic, I do this math. So I do this like a drill, like a fun test with the patient sitting in the room. I pull up the most recent bone marrow biopsy report. I pull up the genetic data. I pull up the mutation tests, which I'll come to the next slide. But this is how you do the math. Anytime somebody has myelodysplastic syndromes of any type, you do this math based on the bone marrow blast cells in the bone marrow. And there's a typo there. The number of neutrophil count in the old IPSS is 1,800 or less. And the new, the revised IPSS is, they divided it based on less than 800 or more than 800. But whatever it is, you can pull up an online calculator and do this math. It kind of gives us a sense of where we are in the journey of MDS. It also kind of gives us a sense of urgency or latency. It also helps us to decide when to move quickly and when to take a pause. So as you can see, the IPSS certainly translates into prognosis. As you can see, the survival is dependent on IPSS. The higher the IPSS, the lower the survival, and the higher the risk of progression to AML or acute myeloid leukemia. So the same way, these tools are precisely based on all these factors as we talked about, and we don't need to remember, what genetic changes and so forth at a common level, but in reality, we do know which are the bad players in the genetics as we see them. So that's important. So this is the so-called IPSS and revised IPSS. So moving to the overall survival, as I said, the overall survival certainly gets affected, and as you can see, a lot is decided based on the chromosomes and cytogenetics. So always I emphasize on the chromosomes and genetics whenever I see somebody with myelodysplastic syndrome, because that's where most of the decision process comes from. So Behar, published this in 2014. So I think from this and subsequent studies, it's more and more evident that certain types of mutations like TP53 and EZH2 and many more, which I'm going to show in the next slides, certainly they changed our basic understanding. Let's say, for example, in this case, these patients were thought to be low risk by revised IPSS. Mind you, when they have any of these mutations, the prognosis gets affected significantly, right? So technically they fall into the low risk, but only by this revised stratification, they are looked a little differently, and it translates into their survival and leukemia-free survival. So this is the list of genes which were studied in the so-called manufacturing of the molecular IPSS tool. Again, nobody needs to remember all these genes, but when you try to look into the algorithm, these are the genes. But most importantly, I want to highlight TP53 as one of the poor players even to date. It's one of those genetic mutations which predict very high risk of relapse even after transplant. So something we do worry about when we see that. So again, this is a picture of the molecular IPSS publication. So as you can see, they split them into these 5 subcategories, and each of them have prognostic relevance. As you can see, as the risk goes higher, from very low to very high, as it progresses, the risk of progression to AML clearly goes higher and higher. The progression to AML and the overall survival clearly is very very clearly distinguished, if you will. Again, this is a picture where you can see the survival, the median leukemia-free survival clearly going down. Leukemia-free survival meaning these patients, when they progress to AML, that means that that is equal to leukemia-free survival as long as they don't progress to AML. Overall survival is how long these patients live in the absence of therapy. So, again, they progress, the number clearly goes down. So this is something we take into consideration. And risk of progression to or transformation to AML clearly goes higher and higher as they progress from very low to very high risk categories. So I want to highlight here one important thing in this graph. I'll walk you through this. I want to highlight some of the categories here. This is the revised IPSS, and this is the molecular IPSS. So, meaning these were compared, side to side. If you see, using the so-called molecular IPSS, this is the number of percentage of patients who were re-stratified from what is called as low risk or, low or intermediate or high or very high into a different strata, if you will. So if you see, using this newer tool, a lot of patients, almost 40% of the patients, were re-stratified into a different category. So that's important to highlight. So a lot of patients who we were describing as low risk or intermediate risk or very low risk based on the revised IPSS could be re-stratified into a different category, which might impact their survival in long run. So this is something we knew about before, but it is actually very good to see, translate into a tool which we can follow along. So with that being said, let's switch gears to the transplant mode. So this is the number of transplants what are performed in United States, and the number has clearly gone higher. and MDS is one of the most common indications for transplant. So I'll talk about the survivals of MDS-related related transplants. So this is the CIB-MTR data, Centers for International Blood and Marrow Transplant Research. So a lot of research comes from this registry. So all the transplant centers in the world actually reports to this registry, and we get a lot of data from it. And it's analyzed every year, and they report it out. It's public information. So as you can see, for related donors, the survivals are somewhere around, the median survivals are in the order of like 2 to 3 years. But I'll show you some of the other slides. What happens after transplant when patients do undergo transplant. So. Again, this is the haploidentical transplant and mismatched donor transplant. The probability of survival is somewhat lower in the haplotransplant and the olden data, but as you can see with time, things are getting better. So haplotransplants are competing in outcomes with a matched related donor and matched unrelated donor transplant as we get better at proper graft versus host disease prevention strategies. Again, this is specifically directed to MDS. As you can see, with time, the outcomes of MDS-related transplants have gone higher. Nothing has changed in a big way, but it's mostly supportive care. How we manage these side effects, how we manage graft versus host disease has changed. Some of these complications which happen after transplants has changed, which really improved the outcomes of patients. So let's say somebody undergoes transplant for MDS. Now that they have high risk MDS based on whatever tool you use, and they undergo transplant when they are transplant eligible. When I say transplant eligible, somebody above 70 years of age, the risk of transplants are too high, particularly after 75 at our center. We rarely do transplants for MDS. So let's say if somebody undergoes transplant, the majority of this is a nice pie diagram because it shows what are the big troubles we expect after transplant, right? So for younger patients, within the 100 days or beyond 100 days. So if you see there's a pattern in what you see here. Before 100 days, the most common problem is often organ failure in younger people, and the same with even in adult population, like in kids versus adults. But if you see beyond 100 days or long term, if you will, the majority of the outcome is affected by the disease relapse. So mind you, the beast in the room is often the disease itself, even after transplant. So again, this picture doesn't say that 62% of the patients relapse after transplant. That's not what this picture is saying. But what happens? What are the negative predictors? What predicts death? What are the things which lead to death after transplant? So roughly about 30% or so patients, 30 to 40%, depending on what data set you see. Patients relapse after transplant, whether it's for MDS or AML. So, but in that, how much percentage, what this is showing here is what that translates into. But this is all comers, patients who die after transplant. What factors really lead to that death of that patient is what this picture is talking about. So this is for match-related donors, but there is the same pattern you see even with unrelated donors or with haploidentical donors. The theme is often the same. Often it's primary disease which relapses, and that really is the one which leads to a lot of trouble post-transplant. If you see, graft versus host disease is a big deal as well, and infections is a big deal, as you can see in any of these pie diagrams. So infections, graft versus host disease, and disease relapse. These are the three big factors what we pay attention very closely after transplant. So again, this is a so-called mismatched unrelated donors. In the algorithm, an MDP recommends, which is an 8-point HLA matching algorithm. Let's say if somebody has 7 out of 8 match or 6 out of 8 match, so what are the outcomes? So, but overall, the theme is the same. That's what I wanted to highlight from these sequential diagrams. So I'll highlight on this particular study. This is a Medicare-initiated study. We participated in this study. It's called as BMT CTN 1102. What they did was, so before the study was published, as you can see, this is a very recent publication in 2021. So Medicare, as you can see, a lot of patients with MDS are Medicare, their primary insurance is Medicare. So Medicare wasn't certain if transplant really saves lives. It really wanted to put that question to test. They really, what they did was very interesting. So let's say I am 64. Let's say, to be more kosher, let's say, I'll say I'm 65. This study was not just purely for Medicare patients alone, but this was 50 and above, 50 to 75. But Medicare was interested in that population, which are served by Medicare. So they looked into the so-called IPSS using as a prognostic tool, intermediate 2 and high-risk de novo MDS patients, and they were not an unrelated donor search or a sibling donor typing was not done by the time of referral to the center, and they were enrolled. So this is almost like I'm seeing a patient for the first time in my clinic, who is eligible for transplant, but we haven't initiated the process. So what they did was, if somebody has a related donor or an unrelated donor, they get randomized to the transplant arm. If somebody does not have a related donor or unrelated donor available, they were assigned to the non-donor arm, if you will, and they were followed along. And this data was published recently. And as you can see here, the overall survival is significantly better in patients who had undergone transplant. So we are talking about patients who are 50 to 75 years of age, who had undergone reduced intensity allogenic hematopoietic stem cell transplantation, and they were followed along. So clearly, even in this age group from 50 to 75, when they have used reduced intensity allotransplant, when there is a donor available, transplant always seems to hold steady as far as leukemia-free survival and overall survival. So this really changed the rules of a Medicare, and a transplant is an approved thing for Medicare. I didn't put that slide. I'll also make a mention about it. So there was one more study conducted by BMT CTN. It's called as 0901. They go by the numbers. So what that study had shown is it enrolled patients with AML, acute myeloid leukemia, and myelodysplastic syndrome. About a third of patients in that study, or 1/4 of the patients involved in that study, had MDS, and remaining had acute myeloid leukemia. So in that study, for patients who are 18 and above, were enrolled into the study up to 65. Patients who had received full intensity or myeloablative conditioning, they had better overall survival, mainly because full intensity transplant reduced the risk of relapse, though full intensity transplant, or the so-called myeloablative transplant, had higher risk of transplant-related mortality or morbidity because of more toxicities, expected toxicities, and there is also higher risk of graft versus host disease with a full intensity transplant compared to reduced intensity transplant. But yet, there was a bigger benefit in the entire cohort in younger patients who undergo transplant, when the indication is AML or MDS, in myeloablative conditioning, mainly because full intensity transplant appears to lower the risk of relapse, because as I have shown you in the previous pictures, the brunt of cause of death after transplant is often the disease relapse, even more than graft versus host disease. So when possible, we often try to balance things out in younger patients, particularly when somebody is 60 or younger, and if somebody has a myelodysplastic syndrome and who has transplant eligible disease status, and they are transplant eligible based on a lot of comorbidities they may have, we do prefer using a myeloablative allogenic hematopoietic stem cell transplantation, which is also called as full intensity and not reduced intensity. So I'll switch gears to aplastic anemia. So I'll come back to those two cases at the end of the talk. But aplastic anemia, we talk. Maybe some of you may have tuned into the other discussion on the other side. So aplastic anemia is a very rare disorder. So it can affect either ages, very young people or people who are above 60 years. So it has a bimodal distribution, if you will. The incidence is less common in the East, in the West compared to the East. So in the United States, it's around like 2 cases per million, but that's more common in Asia for reasons which are not so clear. Maybe it's environmental or related to some of the viral infections which are seen in the East. So some of the risk factors like drugs, toxins, and inherited disorders could be some of the risk factors for aplastic anemia. So in some patients with myelodysplastic syndrome, aplastic anemia coexists in them. So I'll go over some of those phenotypes with you. So this is how we stratify aplastic anemia. Aplastic anemia is less number of cells in the bone marrow compared to myelodysplastic syndrome, where you have a packed bone marrow with very low blood counts. So in aplastic anemia, the bone marrow has less amount of cells, unlike myelodysplastic syndrome, where the number of cells inside the bone marrow is very high, but they die at source. In aplastic anemia, the number of makers of cells are quite low. So again, depending on the level of degree of low number of cells in the bone marrow and in the peripheral blood, we kind of stratify them into severe, very severe, and non-severe. So for severe aplastic anemia is when we consider bone marrow transplant, when they have very low blood counts and they are dependent on a lot of blood transfusions. So this is a case, a 23-year-old college student, presented with heavy menstrual periods and easy bruising, and blood counts were clearly abnormal. As you can see, the reticulocyte count, which is an early baby stage of red blood cell, that's called as reticulocyte, and we can measure it on a blood test, and that's an important way we can see how many red blood cells the bone marrow is making. It's a 2-day young red blood cell in circulation, if you will. So, you can measure it. If it is less than 20,000, that is very, very low. So this patient has very low red blood cell count and reticulocyte count. And the platelet count is very low, 6,000. Normal is 150 and above. And the patient also has very low white count of 0.8. And the neutrophil count, neutrophils are the cells which are important in fighting infections. And that is also very low. And the number of cells in the bone marrow are very low as well, like less than 5% in the bone marrow. And the chromosomes were normal. And when we did a PNH screening, there was a small PNH clone, though it was small, there it was evident. And this patient had history of some autoimmune thyroid problems in the past. So what would you do in this particular case? Would you refer her to a transplant center for transplant workup, or would you give her immunosuppressive therapy along with L-Thrombopag, or would you give her prednisone, and would you give her L-Thrombopag alone? So we'll talk about some of these and how transplant is important in aplastic anemia as well. So again, aplastic anemia is a very broad category by itself, because it can overlap its territory with a lot of other diseases. So we see it more like an overlapping cousin to many diseases, if you will. So, but nevertheless, aplastic anemia, what it means is the bone marrow, which is supposed to be, filled up with nice blood stem cells or early precursors of blood cells, it's filled with fat and it's essentially empty, and it does not have any other good healthy blood cell producing cells. So it can happen because of some of these chemicals or radiation, but most often it's idiopathic, meaning we don't know the cause of it. And sometimes it can be associated with infections or autoimmune diseases. And sometimes it could be from what is called as inherited bone marrow failure syndromes. Some of the common ones we talk about are Fanconi's anemia, and there are a whole host of diseases called as telomere biology disorders, which was discussed, in great detail in the other sessions. Some of you may have tuned in and followed along. So I'm not going to go into details about them, but these are all the causes of aplastic anemia, and we do take into consideration all these factors because what leads to aplastic anemia is very important in the treatment decision process. So as I said, aplastic anemia is, it has too many cousins around it. So it overlaps with too many flavors of diseases, if you will. So MDS can be an overlapping phenotype. So it could be associated with some of the autoimmune diseases like LGL, large granular lymphocytosis. It could be associated with some of these hereditary conditions like Fanconi's anemia. It could be associated with telomere biology disorders. It could be very well associated with PNH. So again, aplastic anemia is not one entity by itself. It can overlap with a whole host of other coexisting disorders, and it's important to identify that. So this is a good slide because usually aplastic anemia is an autoimmune problem where your own T cells, T as in Tom, lymphocytes are attacking your own hematopoietic stem cells and killing them, if you will. So the idea of aplastic anemia treatment is the treatment is often directed against the T cells when you are taking a non-transplant approach. So any drug which kills the T cells or inhibits the proliferation of T cells is the backbone of aplastic anemia treatment. So as you can see, aplastic anemia, we just talked about other flavors which are overlapping on top of it. So this is the broader algorithm we use when we try to figure out about decision about transplant. If somebody is younger than 40 years of age and if they have a sibling donor and they have severe aplastic anemia, we often take them to transplant. If somebody is younger than 20 to 30 years of age, if they don't have a sibling donor, but they are younger than 20 years of age, they do have an unrelated donor. We do a fully matched unrelated donor, to be more clear. We do take them to an unrelated donor transplant. So I'll show you why we do that. And if they are not, meaning in other words, if somebody is older than 40 years of age, or if somebody is young, but still they don't have a matched sibling donor, the current state of practice is to use immunosuppressive therapy like ATG, cyclosporin, and L-trombopag. So again, first-line immunosuppressive therapy, works fairly well. And when I say first-line immunosuppressive therapy, it often indicates anti-thymocyte globulin, the protein which kind of kills the T cells, and also cyclosporin, which inhibits the T cell proliferation. So I'll show you the advent of L-trombopag, which is a stem cell growth factor. It kind of made a huge impact in the number of patients who can respond to this immunosuppressive therapy. So immunosuppressive therapy in frontline is effective, but a lot of these patients could relapse down the line. Particularly look at the outcomes in some of the patients who are 40 and above, particularly 20 and above. So there is a new drug which got added into the backbone of immunosuppressive therapy. It's called as L-trombopag, and when it is added on top of the classical immunosuppressive therapy with ATG and cyclosporin, the responses are quite impressive. At 3 months, a good chunk of patients have responded, and at 6 months, there is a significant improvement in the response rates when L-trombopag is added. Again, this is a non-transplant-based approach, so the current strategy is if somebody needs a non-transplant approach, we use triplet, a combination of ATG, cyclosporin, and L-trombopag, and not ATG cyclosporin alone. L-Trombopag is FDA approved for relapsed aplastic anemia as a single agent, but I'm not going to go into that. But what is interesting, I want to show you. We talked a lot about mutations in the molecular IPSS, but here in this picture, you see that they studied the number of mutations at baseline here, meaning with L-Trombopag or without L-Trombopag. You remember I just talked to you about L-Trombopag being a stem cell growth factor. Anytime we use a stem cell growth factor, we often worry, are we kind of nurturing a specific clone? Are we progressing the aplastic anemia to MDS, or is it really affecting patients in a bad way? So the researchers in this particular study, they have followed the number of mutations at baseline in both the groups. So the B group is the one which received L-Trombopag, and A did not receive L-Trombopag. So what is impressive is the number of mutations are very comparable, but they do go up with time after the immunosuppressive therapy, but it did not negatively increase the number of mutations or did not affect them in a bad way. That's reassuring to use L-Trombopag in patients with aplastic anemia when we do worry before this data that, is it fast forwarding some of the elements of aplastic anemia. So first line transplants in younger patients have very good outcomes. As you can see, this is the reason why we do transplants in the first line setting in younger patients in aplastic anemia. And if you can see in younger patients less than 30 years, if you see the outcomes are very good even with unrelated donor transplants. So this is the reason why many people feel like if somebody is less than 20, 30 years of age, if they don't have a sibling donor, but if they have an unrelated donor, it's still a good consideration to proceed to a matched unrelated donor transplant. But if somebody does not have an unrelated donor available, they do proceed to the immunosuppressive therapies because the long-term outcomes after transplant in people who are above 40 can be detrimental because of other reasons. Again, what conditioning is better is something important to talk about. So again, flu-cy-ATG or cy-ATG, cyclophosphamide ATG are usually the standard conditioning regimens we use, whether it is in the sibling donor or unrelated donor. Usually, most centers use cy-ATG for sibling donor transplants and use flu-cy-ATG low-dose TBI for unrelated donor transplants. Usually, that's the standard of care at most institutions. And we do use a bone marrow graft. So this is me along with Dr. Warkentin harvesting a bone marrow in the operating room. So this is the other way of collecting the stem cells, which is giving Neupogen and collecting the stem cells by an apheresis catheter and on a machine. So this has more number of white cells in the collection. So that leads to a higher risk of chronic graft versus host disease and graft versus host disease in general compared to a bone marrow graft. So aplastic anemia is not a cancer. It is a non-cancerous condition. So we really don't need that so-called graft versus leukemia effect or graft versus MDS effect, what we need in other forms of diseases. So in aplastic anemia, we often strive to get a bone marrow graft because the risk of graft versus host disease is lower. So I'll also highlight some of the pandemic problems. So in the pandemic, this was published right in the early phase of the pandemic because we were struggling to figure out, like, should we cryopreserve these stem cells, or should we give the graft fresh? Before pandemic, we always gave the grafts fresh. The meaning, the grafts were collected and the patient was in the middle of the conditioning regimen, and we gave the graft fresh. So this study coming from CABMTR, mostly retrospective study, had shown that the risk of graft failure was higher if it is a cryopreserved graft. So we often strive to get a fresh graft and give the graft fresh, mainly to reduce the risk of graft failure. Particularly this particular paper is for severe aplastic anemia, but the theme is very common across other transplants as well. So I'll close the talk by showing where the field is going. The field of transplant in aplastic anemia is going. So this is a meta-analysis from the European bone marrow transplant group, where they have shown, let's compare all the studies published upfront allotransplant versus upfront immunosuppressive therapies. So this is in adults 21 and above, right? So again, they have seen that there is an advantage, or this is the forest plot. Anything, it kind of tells you which is favored in outcomes. So it's fairly simple. If it is below 1, it favors this side. If it is more than 1, it favors this side. So as you can see, transplant is favored in patients with aplastic anemia, all comers. Again, that's important to highlight. So with that, the next question is, should we do upfront allotransplant or allotransplant at salvage? So again, this meta-analysis shows that there is advantage to transplant upfront. Again, with that in mind, there is this movement in the field of aplastic anemia and the timing of transplant. Should we introduce transplant early on as we came to know what is a better preparative regimen, what is a better graft versus host disease preventing regimen, and so forth, how to treat graft versus host disease when it happens. So with that in mind, BMT-CTN, which is the largest network of hospitals and centers, which organize large-scale clinical trials, and we are part of it, and many big centers are part of it, and it is planning an upfront alternative hematopoietic stem cell donor for adults 21 and above with severe aplastic anemia using this approach of GVHD prevention called as post-transplant cyclophosphamide. So there's a lot of data that in malignancies, like in other heme malignancies, that post-transplant cyclophosphamide reduces the risk of graft versus host disease very, very significantly. So this is a study which hasn't started yet, but this is probably the way the field is going, to explore the role of transplant sooner than later using even alternate donor approaches, meaning if somebody does not have a sibling donor, we still probably may help the patient by doing transplants upfront is what they're planning to study. Of course, that question is not put to rest yet. We always joke about it, transplant versus no transplant, who you ask, it all depends. So a transplanter is like a nail and hammer, that's what they joke about. But nevertheless, we certainly don't want to harm anybody. So we always look for strong scientific evidence before a decision is made, and this trial is in an attempt to it. So again, these are some of the big conclusions. So we talked about what is a novel way of stratifying myelodysplastic syndrome, particularly helping in the transplant decision process. We also talked about the role of reduced intensity transplant in patients 55 and above, transplant showing benefit rather than non-transplant approach. We also talked about the concept of intensity of conditioning influencing the outcomes of transplant in MDS. We also talked about how aplastic anemia is diagnosed and how we make the decision process of who goes to transplant versus who receives immunosuppressive therapies. We could, going back to the first two cases, the first case we talked about the 62-year-old male with transplant question, right? So with that being said, let's go and solve this case again. Sorry, I should have placed the slides at the end. But if you see, this is a 62-year-old man with not many comorbidities. Certainly, when you do the math using the revised IPSS, using all these genetic mutations which predict adverse outcome, this patient falls into the so-called high risk by the revised IPSS. So in my practice, I would certainly recommend this patient to proceed to allotransplant because of a high risk of progression to AML in short term, whether it is 1 year or 2 years or 3 years, and giving a better survival and leukemia-free survival advantage. And the next patient, we talked about is the aplastic anemia patient. So let's go over with what we talked so far. So this is a young college student with aplastic anemia, and there's a small PNH clone. And I would certainly HLA type this patient and obtain HLA typing of the siblings. If the patient does have a sibling donor, we would proceed to transplant in this patient. If somebody does not have a sibling donor, even then, because this patient is somewhat younger, like in around 20 years, if this patient even has an unrelated donor, I would still consider a transplant for this patient. Certainly discuss the role of transplant and do what the patient feels is appropriate. With that, I'll stop and take questions if anybody has any.
Thank you so much, Dr. Gundabolu, for sharing your time and expertise with us. Do we have any questions from the audience? If not, I will take an online question. The first question asks, what is the difference between a bone marrow transplant and a stem cell transplant?
Yeah, great question. So again, this is an amazing question. So this picture, what I put with Dr. Warkentin, really helps it out. So in olden days, when I say olden days, not 200 years ago, but when transplants came into light, the only way they know, stem cells could be collected, they know that stem cells reside in our pelvic bone and the spine and the skull and the ribs, all these flat bones and the axial skeleton. That's where the stem cells reside. So all the long bones, they go, it's filled with fat as we grow older. So in olden days, when the transplants, the concept of transplants came into existence in late 50s and certainly early 60s onwards, the only way they can collect stem cells is by, let's say, if I'm donating cells, I go to the operating room, they put me under general anesthesia. So there's a patient behind that screen, by the way. so we do lots of bone marrows and aspirates, and we take the stem cells, in this bag, as you can see, right? So that's where the stem cells are, and that's actually filtered out, and we infuse it to the patient, whoever needs it. So the modern way, meaning the modern way include, coming into early 80s. In fact, Dr. Kessinger from UNMC pioneered some of this concept of what we call it as peripheral stem cell mobilization. So Neupogen, or the so-called GCSF, granulocyte colony stimulating factor, what it is called as, it came into advent somewhere around early 80s. So they learned that if you give GCSF, the stem cells move out. So it's almost, I often describe it to patients as, putting some smoke under the beehive, and they suddenly come out and like you could catch them in a mesh. So it's almost like that. So we give them the GCSF. On the 5th day, we filter their blood, and we collect out the stem cells. We separate it out. The apheresis machine really spins the blood at a very high force, and it has the ability to separate out only the stem cells separately. So the modern way of describing is the so-called stem cell transplantation, because the older way is, bone marrow transplant, because technically the stem cells were directly harvested from the bone marrow itself. So that's why the name still remains as bone marrow transplant, but in all reality, stem cells actually, even if they're collected by mobilizing, they come from the bone marrow. So in all reality, they are interchangeable words.
Thank you. My next question is from a patient who's asking if they can have more than one transplant, and would they need to use the same donor for the different transplant?
Great question. So transplants can be of different types, right? So for example, where the stem cells are coming from dictates the name of the transplant. So transplants can be syngeneic, meaning if it comes from an identical sibling. So in olden days, they thought, okay, syngeneic transplants are inferior. This is data from 1980s, but still holds good. For leukemias and lymphomas, we don't do syngeneic transplants because it lacks the so-called graft versus leukemia or graft versus lymphoma effect. So one of the jobs of the graft is not only replacing the new blood cell production machinery, but also going behind the pre-existing cancer cells, and we call that effect as graft versus leukemia effect. right? So when we say, like, can a person undergo transplant using the same or a different one? So I want to draw that line. Where are these stem cells coming from? Sometimes patients undergo autologous stem cell transplant using their own cells for a different reason, and they subsequently undergo allotransplant coming from a different source. Ultimately, the type of transplant and the stem cell source is dictated based on the type of disease what that particular patient is undergoing transplant for. As far as going further, let's say if somebody undergoes transplant and the disease relapse, unfortunately, what we typically do is we do what is called as donor lymphocyte infusion, meaning we use the same stem cell donors' white cells, and we give them in batches of increments, and we give them in over a period of time, over a period of weeks to months. We call that process as donor lymphocyte infusion. But sometimes we do make a choice whether that person needs a second transplant for the same indication, an allogenic hematopoietic stem cell transplantation. So this question is not put to rest. I think it's a very debatable question. So sometimes we make the decision based on whether that patient had any graft versus host disease after transplant or not. In other words, let's say if I undergo transplant for a allo-eligible disease, I did not have any graft versus host disease and the disease relapses, then I might, and I'm still in a very good shape, my transplant physician might choose to use a different donor because of complete absence of any graft versus host disease with the first donor. But this question is not put to rest. I think it's still debatable whether you can use the same donor or a different donor.
Thank you. My final question asks, when is a transplant considered a failure?
So, transplant is we don't take transplant lightly. I often tell patients personally when I talk to them at multiple visits what we have before the transplant decision process. I tell them transplant is more than marrying a person. You cannot undo this process. These cells, once they go in, you just have to deal with it, good or bad, right? So there are good sides of transplant, there are bad sides of transplant. So transplant can be a failure if there are complications related to transplant or if the disease relapses. So if the complications really are severe enough or if the disease relapses, those are the two situations where we consider transplant having a detrimental effect. So failure is a very scientific term as well, not only a normal colloquial term, but if somebody, let's say if somebody has very severe graft versus host disease and really they suffer from it, that's also a downside of undergoing transplant. So oftentimes failure is used when the disease obviously relapses. That's the common terminology. When somebody says, okay, the transplant failed technically if the disease relapsed within, whether it happens within the first 3 months or later on, it doesn't matter. That's when most commonly people say. But I'm also highlighting that, there are other ways people can suffer after transplant, which includes infections and other complications like graft versus host disease.
That's all we had time for. Thank you so much, Dr. Gundabolu, once again for being here.
Thank you for the opportunity.
If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in one of 3 ways. You can send an email to help@amds.org, or you could call the AMDSIF helpline at 800-747-2820, extension 2. You can also submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. We're taking a short break for lunch, and the next educational sessions will start at 1:30 p.m. Central Time. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes this session.